Hi, thank you for the introduction from Susan, or reintroduction for many of you. My name is Vanessa Carmody. I haven't been here in a while, unfortunately. I did change positions. I used to work with Kaiser and their students here, which was such a joy, and I'm so glad to be able to come back here. I've done this presentation before. I believe the last time I did this presentation, I did it in conjunction with Magnification Company, which is a technology-based assistive technology company. Bob Schaefer runs that company. If you ever have any questions about technology or vision-based technology, I'm happy to answer those. I am an occupational therapist, and I love occupational therapy, but this is my first love, was working in low vision rehabilitation. I joined Kaiser to teach low vision rehabilitation and also community. So getting students out in the community and understanding wellness care, understanding not just medical-based care, but understanding that these facilities and these places exist, and making sure that how we can contribute to that, and how we can be educators, and how we can connect people to resources in the community, and making sure if we can be a part of connecting people with resources and with each other, so there's not all this disconnect between this doctor and this medical provider and this service in the community, that we all could work together. That's the dream, and whatnot. And that's certainly something that Michelle Vandendoren, who is the owner of Low Vision Works, had in mind back in 2001 when she originally created the company. She's been around, Low Vision Works has been around since 2001. We are a group of OTs who are throughout the state of Florida, primarily the west coast of Florida, who see individuals in their home and provide low vision rehabilitation. All right, so what is low vision? So this is a technical definition of low vision, where it is vision problems that cannot be corrected, right, by any kind of glasses or medical procedures, contact lens, or surgery, okay? This is a very, like I said, technical definition. I would say that low vision is pretty much any kind of vision that's not adequate for what you want to be able to do every day. So a lot of our clients that we work with, because we've been around for a long time, may be sent to us and maybe they have just a little bit of a vision deficit, but they still have things that they can't do, that the vision gets in the way. So maybe of reading or driving or being able to play an instrument, or being able to interact with people that they love. Kidding. There we go. Oh my goodness, going slow. All right, so do you have low vision? All right, so just as I said, anything that's inadequate or vision that's inadequate for what you want to be able to do is low vision. The technical term, I believe, is 20/70 as far as acuity level. So someone who has 20/20 vision, of course, has what we would call perfect vision. And somebody who has 20/70 vision, right, the individual who had 20/20 vision could stand at 70 feet and see something very well, whereas the person who had 20/70 vision would need to be at 20 feet to be able to see, so closer. So we'll talk about acuity in a second, but so low vision maybe can cause different difficulties in any of the following different areas. But one of the things I put first on here is recognizing faces. So a lot of individuals with macular degeneration or some other condition that affects the back of the eye or the retina, okay, affects their ability of being able to see details. And one of those things that they have the most difficulty with is being able to recognize people, so faces. Faces don't naturally have a lot of contrast. That's why those who perform and whatnot put on a lot of makeup to be able to see features, how clowns do their makeup and whatnot to be able to see different expressions. But individuals who have a central base vision deficit specifically have difficulty recognizing faces, and that's something that we often are working on in training them to be able to recognize faces, using different exercises and retraining the brain to be able to recognize that information. Reading, everything we do seems to involve some kind of reading, from recognizing the shampoo bottle versus the conditioner bottle versus other things in our bathroom, to using a phone, and a tablet. A lot of what our therapists do are working on being able to utilize technology in a world that is full of technology, and how vision is required for that. Different signs and being able to locate different signs and labels, understanding different symbols in our world and being able to process that, cooking, sewing, fixing things around the home, and participating in things that you love, such as active and leisure hobbies, which many of you do here at Parkinson Place. Picking out our matching clothes and navigating, of course, safely in an unfamiliar environment, just as well as a familiar environment. One area that we work a lot with clients on is navigating in grocery stores or navigating to transportation systems to be able to get to grocery stores. So our therapists actively will work with them on being able to navigate in those spaces and utilize the best vision they have available in order to do that safely and effectively. All right. I'm so sorry. I did not put this animation on here, but vision loss is the leading cause of disability in adults over the age of 70 that causes different daily loss, like I said, and different daily skills. Most low vision rehabilitation referrals are because of the following different conditions. So age-related macular degeneration, I briefly mentioned that. So central vision scotoma or area of weakness in your central-based vision. So if you kind of hold out your thumb and your thumbnail, if you're looking at your thumbnail and focusing, that's pretty much your most central vision. And in macular degeneration, that is an area that is compromised. So that they don't know the exact reason, but essentially in the back of your eye, a lot of chemical processes are happening. And in your body is supposed to take care of the trash that happens when all of that happens. And with macular degeneration, unfortunately, that doesn't happen, and it causes a lot of damage in the back of the eye, and particularly into central vision, which is what's required for reading or recognizing details. Glaucoma, which is, of course, a damage to the optic nerve. It often mostly affects the peripheral-based vision, and caused by increased pressure in the eye, and different causes of that. Diabetic retinopathy, which is caused by diabetes. Sugar can affect your vision greatly, and it often will lead to diabetic retinopathy if not under control. Different brain injury or disease, just stroke, can cause a lot of field-based deficits, and neurodegenerative disease, which we'll talk about when we talk about Parkinson's specifically. All right. So how vision works and understanding can kind of help with this presentation, understanding different foundational elements of how light works. So vision works based on light. In the front of your eye, you have the cornea, which is kind of like, if you can think about it like a camera, I think that it's a good analogy to understanding how the eye works, how vision works. And I'm showing you just the eyeball, but I will tell you that the most important part of how vision works is actually happening in your brain, the majority of that, past your eye, and how it is processed into images and what we see. So as light enters the eye, okay, you can think about the different parts in the front part of the eye are managing that, and it actually travels to the back of the eye, into the retina. And I was talking about where the central most portion of the vision is affected. That's why macular degeneration has its name. And it's right here. And right in the middle of that's called the fovea. And that's where the most detail is. As it goes into the back of the eye, I talked about those chemical processes. And it sent us signals down the optic nerve, much like your camera would send something to a computer, and the computer would process it into a picture, much like your brain does. All right. So in the brain, there are different processing centers, and I won't go into too much detail of this, but essentially there are two different types of cells at the back of the eye that analyze that light information that's coming into the eye and sends that information to the brain in order to process, and those are called rods and cones. And primarily, your cones are the centralmost part of your eye, and the rods are in the peripheral base part of your eye. That's why they are, basically they're telling you analysis of motion, so they're warning sensors. So a lot of our patients who have some kind of retinal disease will have some kind of rod or cone dystrophy. And depending on what that balance is, we might see different deficits in their analysis of form and color, or whether they can feel or see, or rather see different types of motion in the periphery. So it's important to understand the foundations of vision, because that's where visual rehab actually comes from. And there are different elements that kind of build in this pyramid, and understanding how it relates to, specifically with Parkinson's disease, is how dopamine affects when there's lack of dopamine, rather, or it's not functioning correctly, on how it can affect each area of this pyramid. Okay, and the foundation is what we're going to talk about here, which is ocular skills, or being able to control the eye under those visual fields, so central versus peripheral-based visual fields, and then acuity, and being able to see not just high contrast, but lower contrast acuity as well. So at the top of the pyramid, I have this little arrow coming out, because at the top where it talks about adaptation through vision, just because we may improve visual skills or improve the ability to see through good parts of the eye, so maybe you're getting more light in there, maybe you have glasses, maybe you've got a correction, so on and so forth, it doesn't mean automatically that your brain's going to be able to process that well, right? So a lot of our clients, we may chain them, for example, to eccentrically view, or use a good piece of vision that's remaining in their central vision. But it takes a while for the brain to catch up to be able to process all that new information coming into the eye. And that's where the steps coming through vision rehab, I don't know why it's shaking, but coming through vision rehab are very important in getting that to that top, which is different areas of adapting, and being able to use that and then build connections in the brain to be able to then interact with your environment using that new vision. All right, so we talked about acuity a little bit. There are two different things that go along with acuity, something called high contrast acuity, and this is many of you have seen a chart like that when you went to the eye doctor, and that's testing your high contrast acuity. This is an example of a test at home test for acuity from Banner, and it is an acuity test that's free to print off and use at home. And then there is a low contrast acuity, which, as you can see right here, okay, there are letters that go all the way down this chart, and this isn't perfect as far as the brightness and whatnot, but when we're testing and considering acuity, we're considering both high contrast and low contrast acuity. So for example, someone who may not have very good low contrast acuity may have difficulty finding that white switch on a white wall, may have difficulty recognizing the edge of the tub on a white tub with white tile, with white towels, with white countertop, with white, everything's white in the bathroom, right? So there's a lot of different, even recognizing, that's why they put fluorescent-based tape on the stairs, or recognizing a curb, or when it's rainy outside, it may be difficult to see things because they're hazy. So low contrast acuity and being able to process information, even with not a lot of contrast, okay, is important in our everyday life, right? Being able to pour water into a glass is not a lot of high contrast in that particular process, but being able to see that detail even without a lot of information or contrast is important, just as important as the acuity if in a high contrast situation. So a lot of times when we are going into an initial appointment with someone, we're looking at both of these, not just high contrast acuity. Maybe they can see down to maybe 20/50 or 20/60 line on a regular acuity chart, but then if in this area there's a big deficit, there's truly some things in their world that they're having trouble interacting with. A lot of times with a low contrast acuity deficit, we're working on being able to modify the environment. So I always have clients who plugging in their cell phone charger and finding that particular piece there, that's a low contrast acuity task. A lot of times we're adapting that. So maybe putting some fluorescent line guide around that particular thing will help add contrast. A lot of times I'm advocating for individuals who are in CCRCs or places where they live, maybe at assisted living or whatnot, to encourage that they provide contrast when they're eating. So they're not always receiving all of these white mashed potatoes on a white plate, because it's difficult, and it's difficult for them to see if they have a low contrast or contrast acuity deficit. We talked about visual fields, and we talked about just the very central part of your field is only about 20 degrees. That's where you see detail. The rest of it is your peripheral-based field, and that's used, of course, for identifying moving objects towards you. Like if the sky was falling, you would recognize it with your peripheral field, hopefully. It's your recognition, right? So it's your warning system as far as your peripheral field. So a lot of patients who have maybe glaucoma or some other peripheral-based deficit, and it's natural to lose some of this as you get older, okay, about 10 or 15 degrees as you get over the age of 65. You might find yourself running or bumping into things a little more, and that is because of a little bit of a peripheral-based deficit. More so for those who have a neurological condition, either neurodegenerative or post-stroke or something like that, damage to the brain, because it's not processing that information, or there could be a field cut as well. So a lot of damage in that particular spot can cause a lot of issues with navigating, particularly in unfamiliar environments where things, maybe you know your house, but maybe you go out to a friend's house or whatnot, and you're not quite sure of the layout, or a grocery store or a new bank or so on and so forth in the community, or navigating, across a road even and whatnot. There's things changing in that environment. It's dynamic. It can definitely be a safety hazard and also make it more difficult without peripheral vision that's intact. So this is one thing that we work on a lot, and with every client, is kind of making sure that the foundational skills or ocular skills are in place and that are a level, it's almost like a tune-up is what I say for individuals. Regardless of their disease or condition or anything, we're always going to make sure that these areas of vision or ocular skills are in their best shape, right? Same thing as if you were working out these muscles and whatnot, or endurance. We're working on these particular ocular motor skills in order to be able to process or gather that information effectively. So, for example, accommodation is a skill where we use it often, where we're focusing up close on something. Maybe we're reading something. Maybe we look up at the television. Maybe we're reading the television guide or looking at our phone or something like that, focusing up close, and then we're focusing far away. Well, that's a skill, being able to, there's a lot of elements in your eye that go into that, the flexibility of your lens, for example, or the little muscles within your eye, also your iris and controlling the light, and to be able to focus up close versus far away. There's a process there that happens, and if you don't do that often, okay, or you don't practice it and whatnot, it can become affected. Also, in certain neurological conditions, that can become slow, and it can cause a lot of fatigue. And so recognizing that and being able to practice specific exercises is something we might do for someone who's working on accommodation, and being able to do those particular tasks if they're important to them in their life. Saccades would be quick movements of the eye, so being able to control. We're using saccades all the time, where we're moving our eye from one place to the next, or one piece of detail to the next. This is an example of an exercise that we use with individuals called 4-square saccades, where we actually use these 4 different boxes and have them move their eye from the first letter in the first box in the first line to the second letter and then back. And they're working on eye movement specifically, go to the second letter, and so on and so forth. It's called what's called a dual task challenge. So it is something that we often use for someone who may be a little bit higher level, but it adds a cognitive challenge. So that means that they are working on effectiveness or efficiency of being able to move the eye. And that can really increase or improve their ability to control when they're reading. So with reading, we're looking at each word kind of with quick saccades, okay? And so when we're working on exercises, we're working on, again, the effectiveness and efficiency of being able to use your eyes to gather information. So this would be an example of an exercise for that. It says scanning, and it should say scanning, okay? But, whatever came to mind there. But anyways, scanning would be actually being able to look around the room or move your eye across a line without losing your place, or without losing your place when you're moving from one line to the next line when reading. Scanning at a grocery store and being able to locate information while your eyes are moving. So working on, again, preparatory-based work and vision rehabilitation to be able to improve that skill to be able to make it more efficient and effective without you getting fatigued or tired. And pursuits would be following different moving pursuits and tracking kind of go together, but pursuits would be following and then fixating on something that's moving. So a lot of this has to do with mobility around, for example, moving vehicles or people when you're in a crowded place. And then fixation is being able to actually fixate on something and make sure the central part of your eye, where you have the most acuity or most vision available to you, is being able to see something with the most detail. Convergence is the movement of your eye inward. As something comes closer, you have to kind of almost cross your eyes to be able to have that ability to use both eyes to focus on a particular object. With a lot of individuals with low vision, they clearly have one eye that's better than the other, and we may not be able to use both eyes together. And depending on the visual rehab process and where their acuity lies and the ability of each eye, we may have to train one eye separately and kind of make it a more dominant-based eye. Depth perception goes along with both eyes working together and be able to see how far something is away from you and reaching for things like light switches and those kinds of things, or fans, reaching into to grab something out of a cooler or reaching into your cabinet and being able to judge that distance. It starts with your vision. Binocular vision is just all of those skills put together with both eyes together, or bi being two. And then eye and head and foot-eye coordination. So head coordination is not something that we often think about, but there is an element there that is greatly involved in how you're processing information with your vision, is how your head is coordinating with your eyes. There's a lot of natural reflexes that go along with that sometimes can get out of whack. And a lot of my patients, when I first see them, if they've had low vision for quite a while or vision deficits in any level, often will choose to not use their vision first. They might just be reaching. And then we lose a lot of that hand-eye coordination without using our eyes to look and first and then reach for something. We talked about everyday tasks and being challenging, and reading mail, medicine bottles, facial recognition, and watching TV, of course, is a huge one. But grooming as well, finding things on a counter. All of these can be improved by improving some of those foundational skills, but then actively practicing them in real life as well. Reduced self-esteem and self-confidence is something that I run into a lot when there's any kind of vision-based deficit. And then, of course, the diminished ability to live independently can always come into play. Honestly, that's if for anyone who cannot do something that they used to and want to do or expected to do. Specifically with Parkinson's disease, I want to highlight some of those areas. We do work with a large number of clients who have neurodegenerative-based conditions, including Parkinson's and Parkinsonian-based conditions. Visual dysfunction is definitely increasingly recognized as a common non-motor aspect of Parkinson's disease. Specifically with visual acuity and color vision, as well as higher order visuals. So some of those tasks of it making it fatiguing after a while, processing of blue light, particularly processing and needing more types of brighter light as well. Changes in vision can result of visual acuity, contrast. We talked about the contrast element with that chart that got lighter and lighter. And pupil reactivity, so that's even the iris and the control of the iris and the speed of which the iris changes to be able to go from a darker room to a lighter room, or controlling glare. Maybe if you can think of in a bright part of the day, if you go open the mailbox and you get a white piece of mail out, it kind of is like this a little bit and whatnot. And controlling that can be a little bit slower and then maybe not as accurate and can cause some discomfort. Eye movements, so I talked about the saccades and the quick movements of the eye can be affected in accuracy and also speed, so being able to move your eye quick enough and maybe move it to the right target. Motion perception, so that mostly in peripheral base, so understanding not only where your own body is, but also things around you. Visual field sensitivity, so having different sensitivities in your both central and outside fields come in and out, or be dependent on your fatigue level a lot of times. And then processing speeds I mentioned, that's mainly in the brain. So being able to process that light information after it comes into the eye can be all affected by this particular disease. Dry eye, yes. Okay. So there's a lot of information on this slide. You can take a picture if you'd like, but I think you all know this and experience this. It's caused by several different factors, particularly dysfunction affecting tear production. Okay, and side effects of medications are also a big piece of this puzzle. Gland dysfunction, or the oil glands in the eyelids. And then the uncontrolled, or the blinking and the twitching and whatnot, is also a piece of this that can cause and contribute to dry eye. And I put in green that it's a comprehensive approach. So if we have someone who's experiencing dry eye, which honestly, it's not just with our individuals who have PD, but across the spectrum of individuals who have a vision-based deficit, oftentimes will have something that's contributing and causing dry eye of some kind and discomfort in their eye. And a lot of times that's making sure that, of course, they understand what's going on, communicating with the doctor, making sure that medication, if there needs to be an adjustment, and something, use of artificial tears and understanding which and what and when is a big thing that we'll work on with individuals. Any lifestyle changes, and by that I mean like how active are they and what environments are they in, and filtrations in their home and different places that they go. Anything that's causing unnecessary additional irritation to their eyes and their environments, and understanding that is really key as well. All right. I wanted to at least mention light therapy. I have questions that are asked to me quite a bit, specifically by those with PD, and talking about what is light therapy and what does it have to do with Parkinson's disease specifically. So what light therapy is essentially being able to control how much light is actually provided. So light therapy would be providing additional light, and it's used in other base conditions, including depression and anxiety and other brain-based disorders primarily. Research has shown that bright light therapy, so there are specific lights, can be beneficial for managing symptoms that are caused by basically dopamine not affecting the eye processing light correctly. Low dopamine levels can make it very difficult, again, for adjusting to low and bright light, and there's a lot of need for further research and specific daily doses and light intensity, wavelength, and whatnot. It's called photobiomodulation, if you'd like to look up that huge word, or you can just look up light therapy. But it primarily, in this case, is helping control circadian rhythms and alertness. So helping control some of those changes in your alert level and your fatigue level throughout the day. This is a guide directly from a research article that was recently published, and I'm happy to share that, but talking about specifically and using light therapy to help with sleep. We know that there are different elements of being able to recognize PD earlier on, and from research we know part of that is affecting different effects with sleep and on diagnosing earlier based on that being a primary non-motor symptom, and that's primarily due to the effect on circadian rhythm. So circadian rhythm, of course, is controlled by something in the middle part of our brain called the suprachiasmatic nucleus, believe it or not, that exists. And it's something that is controlling how we manage light and use light to manage our wake and sleep cycles. And that's greatly affected by the mismanagement or lack of dopamine in the brain. So this is where light therapy and the idea of light therapy came from. And again, lots of research is needed as far as the dose intensity of this, but it may be something that you would like to discuss with someone like your doctor or asking about it, especially if this is something where you're in the morning, particularly if you're just fatigued all day until maybe 2 or 3 hours in the evening, despite medication and whatnot, or having a really hard time managing your energy levels throughout the day and can't really get it onto a really good pattern. A lot of times that's due to a sleep-based deficit in some way. Either you're continuously in a light sleep, so there's different stages of sleep and not getting any kind of deep sleep. And a lot of times that's affected by how we process light throughout the day. So anyways, wanted to make sure that I was at least mentioning that. Everyone asks about blue light and screens and so on and so forth. And just to provide a little bit of education about that, this is a picture of an iPhone and how you can see how much blue light you're exposed to all day. Well, not blue light, but daylight-based wavelengths. So higher-based wavelengths or higher Kelvin levels are considered brighter or daylight-based or whiter light and whatnot, and keeps track of how much you're exposed to there. But blue light is basically very difficult for your eyes to process. It scatters when it enters, so different colors of light are processed in different ways in your eye. And blue light is very easy, or very difficult for your eye to process because it scatters in your eye. So it takes more energy, more metabolic energy from your body and brain to be able to process that. That's why it can lead to eye strain and fatigue, and it can disturb sleep patterns. So at nighttime, just as a lot of our clients, we will give them all yellow glasses to use at nighttime before they go to bed. Even if they are watching TV, the yellow glasses can help filter out some of those cheap yellow glasses. I'm talking like safety yellow glasses, nothing crazy expensive, right? Like 50-cent yellow glasses from Harbor Freight will work just fine. But to help kind of bring back in some of that pattern of being able to, at nighttime, the blue light naturally would go down. So if you think about how our body has evolution has affected circadian rhythm, it used to be, no light, right? It was the sun that determined when we were awake, and it went down, right? And then we had fire, so we extended that a little bit. And then flash forward in history, we all have LED lights at the end of the 1990s, and that changed everything, right? And then, of course, screens and whatnot all came into this. So managing and making sure you have what's called a good sleep hygiene kind of schedule, where 2 or 3 hours before bed, you start kind of helping that melatonin signal. All melatonin do is this little character. If you can think about melatonin as this little character in your brain saying, it's dark, because that's its only job. It's dark. It's time to get ready for bed. So melatonin supplements can help in certain cases because it does help, but honestly, your environment and what you do each night are very important to helping that natural cycle come back. All right, so we talked a little bit about Low Vision Works and who we are. As far as we are a medical-based company, so occupational therapy. We come out paid by insurance to go through, again, a low vision rehabilitation training program. Again, we're interested in your goals and what you want to be able to do. That's what occupational therapy is. Oftentimes, we're referred to or your referral will come from an optometrist or somebody who's one who would be your glasses or magnification or something like that. A lot of times that will come from what's called a special optometrist, which is a low vision based optometrist, or someone who works with individuals who maybe have 20/70 or worse vision in one eye or the other. But that doesn't have to be the case. Sometimes it'll come from someone post-surgery. We'll see some people if they have a family history and whatnot. We may even see them ahead of time. We see individuals who are referred to us by neurologists, who are referred to us across the spectrum of care. If there's any kind of vision-based issue, all we see is individuals for vision rehabilitation. But again, we're still occupational therapists, and we work toward goals. We all see individuals in their homes and their communities, so wherever they need and whatever they need to work on. For however long they need to work on it. All right. So this is a picture of Michelle, actually, the owner of the company there, and that's her mom. And this is from a commercial and whatnot. But this is a good depiction of some of the exercises and whatnot that we might do in the home in preparation for doing a more functional exercise. So we might be working on these worksheets before we might be going into the kitchen and working on being able to read a recipe and walk through that recipe and make that recipe together so that it establishes. And again, even though we're working on those skills, the basic skills of being able to read and all of that, we got to put them into action. Otherwise, the processing in the brain doesn't happen. So that's what we do in the brain and, in the home, and then also in the community with anybody. We also do a lot of home safety and a lot of lighting and glare training with individuals, a lot of education on lighting for what you want to do, your daily life, what would help with different glare-based issues, and also any kind of equipment-based training. So again, when I did this presentation last time, we had Bob here as well, who does a lot of higher tech-based elements. So an optometrist may do, a low vision optometrist specifically, will do a lot of more optical, so higher powered glasses, those kinds of things, maybe prisms as well, different optical based elements. And then someone who's an assistive technology individual will work on technology based elements for magnification. So maybe someone who has very, very poor contrast. The only way to really improve that with magnification involved would be in a technological way, so a digital magnifier versus a handheld magnifier or something like that. We do mobility training and a lot of community resource connection. So getting someone connected with any and whatever resources available to them in the community, and making sure that they, any kind of resources that is either at a city, county level, at a state level, national level, and whatnot, getting them connected with that as well. A lot of handwriting as well, and reading training basics. All right. All right, how are we doing on time? Pretty good. All right, so I always add in something about falls to a presentation. This is from a presentation, a national presentation that I did for Macular Degeneration Association, so MDA down the hall, and whatnot, and an acronym kind of vision for understanding, particularly for vision and how vision is involved with fall prevention. And these are kind of some strategies that I put into this acronym for kind of understanding and helping you remember how vision is involved in fall risk. And preventing that. So with vigilance and making sure staying aware and alert, and making sure that you're taking control of your wellness, so making sure that you're taking care, of course, as all of you are here at Parkinson's Place, your own strength and your ability to stay physically active and moving, and illuminating, lighting and contrast. I talked about contrast a little bit and how it's involved with safety and being able to navigate and be able to utilize the elements in your environment. So one of the first things our therapist does when they go into someone's home is look for areas of contrast and least contrast where there might be a potential for a fall, and adding tape in that area, or immediately adding some kind of, so a lot of times we're asking individuals, I know everybody likes to have white towels because everybody likes to bleach all their towels. So a lot of times we'll encourage them, maybe not get black towels, but maybe a blue or something like that. So simple ways to add some contrast. So add maybe a tray to where they do their medication so they're not having white pills fall on a white counter, those kinds of elements right away, so we can add some contrast back into the environment to help prevent different hazards and different falls as well. Again, clearing hazards in their home using a checklist. We have a very specific checklist for that. Organization, so keeping things clear and in order. So I'm smiling because I saw a patient yesterday where papers are just everywhere, and it's very difficult to navigate that when you can read one paper at a time and you have to bring it to the magnifier and the light and make it perfect. And we get so much mail and going through all of that. And then we get digital mail on top of that, and digital messages on top of that, and paper here and paper there. And then if we live with another person, we have their paper as well. So keeping things organized and clear, things that have a place, go in that place every time is a huge thing for preventing falls, because looking and moving and and turning quickly, or maybe I thought, or I'm not sure the remote, or so on and so forth, can cause a lot of changes. And we're thinking about what we thought we saw versus walking and managing our environment and communicating, and of course, maximizing our remaining vision as much as possible. So I talked about manipulating the environment a little bit, and I think I mentioned pretty much all of that already, but illumination for lighting, making sure that even in the bath and shower that there's a light in there, or that you have enough lighting throughout your home for what you need to do, not just adequate, like enough for, and that's a catch-22 sometimes, because again, I talked about how light and managing light and glare can be an issue. So making sure that if that's something that you have something that adequate lighting, but that it is also comfortable lighting for you as well, for what you need to do in whatever space that you need to do. All right, and this is where I was talking, where Bob was talking about technology. There is a lot of technology out there. These are a lot of the high-tech items called wearables that are out there right now. There are a lot of AI-based devices as well that are wearable that will actually tell someone who is blind or has low vision what's in front of them, who's in front of them. They're not perfect. They work okay, and there's a lot of concerns for privacy, in my opinion, with a lot of those technologies. However, for some people, they're life-changing as far as for what they want to do. Can you imagine if they're seeing their grandchild's face again? You know, that's a big deal to them. So we work hand in hand with technology, whether that's someone, if their goal is that. We also still work with a lot of individuals who are volunteering heavily and or working in the community, and a lot of times technology is the way for them to continue to do that. All right, this is just an example of more technology that exists out there. All kinds of weird things that exist. All right, and every one of these is going to be animated. But anyways, that was just a quote by Dr. Fletcher. He's retired now, but he is one of the leaders in low vision rehabilitation, and he's talking about not providing low vision rehabilitation to a patient with low vision as kind of like not providing any kind of rehab to someone who has a prosthetic. All right. So sorry, it's going to go through these one at a time. Okay. I think quality of life is bolded at the bottom there, and that is our major outcome that at 6 months after rehab or whenever it is, we always do a measurement scale of quality of life, and the goal is, of course, for that person to be able to do what they want to do or have to do or expected to do in life, so working toward goals for them. For candidates for low vision rehabilitation, so I talked about those conditions and primary referral for who we're getting into low vision rehabilitation. So I mentioned the 20/70 acuity number, but also any kind of peripheral or central-based vision loss. We've gotten a lot of individuals who come to us who have a neurological-based condition. A lot of times they're getting used to using higher-powered glasses, and they are going through low vision rehabilitation with us to get prepared for or be able to utilize those with less fatigue and less strain on their eyes. So maybe they have some prisms that are put into their glasses that they're having difficulty with, or maybe they go to optometrists and say, I need different glasses for reading and using the computer, some for watching the TV, different environments and whatnot, and then getting used to those. A lot of times they'll go through a vision rehabilitation process. And it can be something simple like that may be a shorter plan that we may have with them, to someone who may all the way through who I work with, which I work with individuals who actually have implants into their eye of telemicroscopes, who have advanced geographic atrophy or an advanced form of macular degeneration. And that's a whole different ballgame of working with an individual and training them again to use an implanted optical device into their eye. So again, lots of different areas of recent research, recent FDA approved availability for different medical interventions. but a lot of times we're receiving that patient and making sure that we're, again, involved in that process every 6 months to make sure that it's agreeing with them and that we're working with them on maintaining those visual skills and making sure that they're at a threshold and being able to do what they want to do effectively, even if they're receiving shots in their eyes or any kind of medical-based intervention or post-surgery. All right, decreased contrast sensitivity, that was that chart again for kind of low contrast acuity. So working on making sure for safety that we're working on different ways of adapting and or working on making sure that we're training those visual skills for being able to control glare. I mentioned that being an issue. Light art, dark adaptation, so going between different areas of different lighting. And being able to train the eye and the brain to be able to adjust to that. And emotional adjustment also to losing vision. It's one of the most feared things among older adults is losing vision, honestly, among anybody. And then having difficulty with daily tasks due to any other sensory deficits and not being able to adapt. So losing vision later in life is very different than losing it younger in life. And a lot of times there are other sensory, so maybe hearing or touch or feel and those kinds of things are not quite there. So whereas when we're younger, other systems may adapt. It's a little different when you're older. So working on some of that and being able to train what that looks like in a multisensory world is a lot of what we work on with individuals as well. All right. This is our phone number. You can absolutely call it and find more information, or I'm happy to talk with any of you as well. But understanding that that's what low vision rehabilitation is, and I wanted to at least touch on Parkinson's disease specifically as well, and kind of what low vision rehabilitation looks like, because it is Low Vision Awareness Month in February. It's almost at the end of the month, so hence why I'm here. But Macular Degeneration Association, like I said, is down the hall with Donna Magnification Company. This is just their information as well, because they've done this with this presentation with me prior in the past. So I wanted to make sure I mentioned them. That's it, everyone. Are there any questions? Thank you. All right, no questions? That's okay. Anyways, if I'm happy to stay up here for a while if anybody has anything that they'd like to say. Hi there. All right, and I'm happy to answer any questions you have. All right, bye now. Go back 2 slides. Can I actually go to the slides? That's the question. Window, community, share, success. Okay, maybe. No. I'll go back. I can do it. Okay, I'm going to share window. I'll get it to you. Sorry. Technical difficulties. I'm click happy. I'm like, oh, it's done. X. On to the next. But yeah, anyways, I'm happy to give the phone number again as well as a business card.
I bet you got it memorized.
Yeah, you would think, but I don't. I should.
Oh, she doesn't.
I should have it memorized.
There you go.
That's the phone number if you'd like to call. I tried to make it big. For some reason, it made all those shadows, but, I don't know.
Thank you.
You're very welcome. Have a great day.